and welcome to a very special interview show of the Prode. Tonight, we confront a critical issue that is reshaping global health landscape, the M-Pox outbreak. As this crisis unfolds, it has sparkled significant challenges to the healthcare systems worldwide, which has led to urgent conversations about effective measures, international collaboration, and the path forward. We are honored to join by Dr. Angelique Coetzee, a distinguished medical professional and public health advocate who has been instrumental in addressing crises like this. With her extensive experience and deep commitment to global health, Dr. Coetzee brings invaluable insights into how we can better promote these vulnerable populations and the lessons we must draw from past pandemics and how nations can work together to navigate the complex health emergency. Thank you very much, ma'am, for your time and a very warm welcome to the show.
Thank you so much, and a very welcome also to your listeners and viewers out there.
Ma'am, I would like to begin the discussion by asking that, could you start by giving us an overview of the current state of the Mpox outbreak? How widespread is it? And, what are the most concerning trends that you are observing?
I think before we start, it is important to just understand that we called Mpox a zoonotic disease. It means it started between humans and animals. So that's one of the things, and it is endemic in about 11 countries in West and Central Africa, and with dozens of cases, what we are seeing in Cameroon, Nigeria, Central Republic of Africa, and also in the Democratic Republic of the Congo, which so far has the highest burden. It was first identified in captive monkeys, and African rodents is also to believe to be the natural reservoir. And we also saw infections in squirrels, rats, mice, monkeys, and all of that. So just to go one step back, the first outbreak of human monkeypox outside of Africa occurred in 2003 in North America, and that was linked with infected pet prairie dogs, which were at that stage housed with Cambian poached rats that have been imported from Ghana. And that outbreak led to over 70 cases of monkeypox in the Mpox in the United States. And since May 2022, we saw multiple cases of Mpox identified in several non-endemic countries, as we have talked. So monkeypox in Africa, what people forget to say is that it actually started in 1958. We saw the first Mpox discovered with outbreak of pox-like diseases, and it were observed in monkeys and that were kept for research purposes. And then there were frequent outbreaks in Africa, 1970, then 1997 again, 2000, 2009, 2003, and so we can carry on with all these cases. And then in 2023, we saw there were around about in Africa 14,625 cases, and in May we saw this year 7,851 cases, especially with grade 1. And this is important for your viewers and listeners to understand. So if we look at what you have asked, the mode of transmission, as I've already said, it's infected animal, that people eat, or dead mice or rodents, and especially in Africa, they will cook it and they won't cook it properly. We know that originally that it doesn't spread easily between people, although now that changed a bit, and it's very important to understand that human-to-human transmission occurs through very close contact. It might be with infectious material from skin lesions or respiratory secretions of an infected person. That's why we say it can be spread via droplets, especially grade 1 and 1B. It can also get transmission via the placenta from the mother to the fetus. So it can lead to what we say congenital monkeypox. Or again, there might be close contact during and after birth, when the baby goes through the birth channel. So, and as I've already said, eating of inadequately cooked meat. So what we also see is that this is a virus infection. It's a zoonotic, as I've said, it's a virus infection. And we need to understand that there are two clades, the clade 1 and the clade 2. So, and it's important to understand because it comes back to some of the symptoms that you have asked. So clade 1 was formerly known as the Congo Basin or Central Africa, with a case fatality rate of around about 11%, human-to-human transmission. Isolated isolates. We saw some of these isolated outbreaks in the Gabon, Cameroon, and again DRC, with that big outbreak last year in DRC. So it's more common than the West African glade. And the West African glade brings me to the glade 2. Glade 2B is the one that we are currently seeing in South Africa. So glade 2 was formerly known as the West African glade, with a case fatality rate of less than 1%, less transmissible in humans than glade 1. Remember, glade 1 can spread via droplets between people in very close contact, although glade 2B is much more, it's not a sexual disease, please don't get me as wrong, but it's more seen in men having sex with men, that type of close contact. Also, the mucous membranes can be affected by this virus. And this, we saw isolated outbreaks from the 2A, especially in Nigeria, Sierra Leone, and USA. So we need to understand that there's an evolution. This virus mutate. So glade 1 had now mutated in glade 1B. And as I've already alluded to it, this is the fast-spreading viral infection between the two clades. And glade 1B, as again said previously, it's got a higher mortality rate than glade 2B or 2. And unfortunately, the West hasn't taken a lot of notice about these viral infections, these M-Pox over the past few years. And only now, when it starts to have an impact in some of the Western countries, the first world countries, so all of a sudden, everyone now jumps onto the wagon and want to say, we need to protect and we need to make people aware. But as I've said, it's been in Africa for many, many years. And while it didn't affect first world countries, no one really, took notice of that. So also, let's look at the type of what we call pathogenesis, or how does it spread. It's more, it's a virus infection, as I've already said. And the first 4 days before you start with having, clinical symptoms, you will have what we call prodromal symptoms. You might present with a fever between 38 and 40 degrees Celsius in South African terms. You might have a headache, myalgia. You can have fatigue. This is a typical virus symptoms. It can mean you can attribute it to flu or any of the other viral infections because of the common fever, headache, and body aches and pains. But what makes it different from any of the other diseases that have skin lesions like smallpox or chickenpox is the lymphadenopathy. So these people have enlarged lymph nodes in the neck, the oxals, and in the groins. And your infectious patients, the patient that is infected during the first 4 days before they start with the skin lesions are contagious. Then what they will then maybe have after the lymphadenopathy, so the lymph nodes appears about within 2 to 3 days after the fever, then you will have the rash. The rash will appear 1 to 3 days also after the onset of the fever, and it would normally begin in the oral cavity, the face, then to the rest of the body. However, clade 1b is much more, has these skin lesions in the face and the rest of the body, while your clade 2b it's got less lesions. So the pictures that's normally been shown is more of a clade 1 than a clade 2b. So if we then look, those skin lesions can also include your hand palms and your soles of the feet. And it might be a lot of lesions. So, but first of all, it looks like it starts with what we call the macular papular type of lesion. It looks very similar to measles or German measles in the beginning, with that reddish type of fell or skin lesions. Then it goes over to become a vesicular, and then it forms these pustulas that you can see in all the pictures that's out there. Also, in 30% of cases, it affects the genitals. About 70% of cases will have oral mucous membranes. That's why if you then have oral sex with someone, that might be a huge problem if you have those lesions in your mouth. And so it's spread through the body, and it can be around about 2 to 10 millimeters in size. So your lesions in the pustular phase is 5 to 7 days, and then it makes a crust. So when the crusts start to form, takes about anything between 7 to 14 days. Also important to understand that this condition will resolve around between 3 to 4 weeks after symptoms. And once if they have these crusts on their skin, they are then no longer considered to be infectious, once if they go into the crust phase. So again, important to understand that in Nigeria, there was the outbreak there, re-emerged around about 39 years after the last reported case. And a lot of these people, especially with clade 2b, is people who have a compromised immune system. And that might be due to what we normally call HIV, patients that's got HIV or don't know that they have and not been treated, or they default on their treatment. So it brings down their immune system. And then when they have this very, very close sexual contact, they are then the ones more susceptible of getting clade 2b and they would be very, very sick. They would normally end up in hospital. So you might see a patient with light, infectious skin lesions, not a lot, not like the clade 1b. And these light skin lesions or few skin lesions, I might then have, close contact or sexual contact with someone else. And that person might be immune compromised. And that would be the person that would end up in hospital or die from the disease. So we also need to understand that previously most of these outbreaks affected the children and rural dwellers. We're now talking about M-Pox in general. And the cases were mostly, as I've said, between young adults and people living in the urban and peri-urban areas, and most of them were males. So when we saw the 2022 M-Pox outbreak, again, the community that was at the highest risk were the male to male or men sex to men age under 50. also need to understand that there was viral shedding has been reported in feces and contact with the rectal mucus area. And again, that might increase the likelihood of having your M-Pox transmission, especially under men having sex with men. I also would like to draw your attention to, the different types of viruses that you need to just being able to distinguish between. So if you look at your M-Pox virus, the fever that starts before your rash, you will have your varicella, your smallpox, or your varicella zoster virus type would also have a rash 1 to 2 days. Then you've got your variola viruses also have a fever before the rash, and then some of your enteroviruses. But the biggest difference between all 4 that I've now mentioned is the monkeypox having these lymphadenopathy, which none of the others have. And it's a very, very important distinguish characteristic between these type of infections, and so it becomes also a clinical diagnosis. So you need to make sure that the patient doesn't have chickenpox, doesn't have measles, doesn't have smallpox or molluscum contagiosum or any other herpes infection. But as I've said, you look for lymph nodes in these patients. So if you look at the complications of these patients, you can get secondarily bacterial infections. You can have lung pneumonia. You can have gastrointestinal involvement. Those patients can have severe nauseousness, vomiting, diarrhea. They can have sepsis. They can have encephalitis. And they can start with a bleeding disease as well. And as I've said, so how do we then make these diagnoses? The best way would be to get a sample or a specimen from the lesion itself, where you take a direct sample or a smear from the exudate from your vascular lesions or scabs, and send that for PCR. You might look at the full blood count. You can look at some of your liver functions that might be abnormal. But important is that most of these infections, whether it's grade 1 or grade 2, especially grade 2, is usually self-limiting. So we manage these patients symptomatically, with analgesia and antihistamine, something for fever, something for the body aches and pain. The antiviral drugs approved to treat smallpox, including tacovirimat and brincidovir, can be potentially deployed for use on treating monkeypox or M-Pox. So, and people who have been vaccinated for smallpox, but there's normally the elderly patients, the older patients, which have some immunity, and that is also why we see it more under the younger people than the older people. Unfortunately, your tacovirimat and those are quite expensive, and you need to have 2 dosages, and we will only give that treatment for hospitalized or severely ill patients. Then we also need to understand that the vaccines that is currently there, just to give you a bit of background, we know that the vaccine against that we are used to protect us against M-Pox, it's got about 85% efficacy, and the one that protects against smallpox at about 80 to 95% efficacy. Unfortunately, as I've said, around about the 70s, we stopped with vaccinating people for smallpox because we believed it was eradicated from the population. And now we're sitting with that more than 70% of the world's population is no longer but protected against smallpox. Therefore, they don't have that 80 to 95% immune system resistance against M-Pox. And this is also why children and younger people are much more affected than the older people. We also know that there's antibody cross immunity between the smallpox and monkey or Mpox vaccines. So there are two licensed vaccines in the United States to prevent smallpox. It's a live vaccine, and unfortunately, it needs to be administered in 2 doses, given 28 days apart. And so, you know, they're still busy looking and developing new vaccines. So if we look at, you know, I've now been exposed to someone, what do I do? Again, vaccines as post-exposure only for high-risk contacts, and it should be within 4 days and up to 14 days after contact. And then if you give it between 4 and 14 days, you might then reduce the symptoms of the disease, but not to say that you can prevent the disease. Immune globulin is also available and can be used as a prophylaxis for severely immunocompromised patients, although the benefits of this still remains very unclear. How can I prevent this from happening to me? We need to isolate your infected person, you know, put him in a room, him or her, you know, take precautions, use a face mask, protective gear, avoid close contact, skin-to-skin contact, especially if the patient's got the Mpox rash. Don't do that. Don't touch the rash of persons with Mpox. Do not kiss or hug or cuddle or have someone with Mpox. Do not share eating utensils or cups, because we don't always listen. And do not share linen. And then the old favor is you need to have good hygiene practice, the washing of your hands, the sanitizing. Then, as I've said, you might look at the vaccines that's available, but again, the vaccines will only be available for close contacts. And people, you know, it will not be given randomly, as we have seen in the case of COVID. Also need to make you aware that the vaccines for Mpox are quite expensive. It's around about $100, which is quite high, especially for Africa and the ordinary people in Africa. So we do have a few challenges with Mpox disease. One of the challenges is the longer incubation periods that we're now starting to see, anything between 5 to 21 days. It's a long period, makes it difficult to see or to sometimes trace your contacts. What is also difficult is this isolation for 4 weeks that you have once if you've got the symptoms. And then there's the stigma, especially around a male, sex to male. And people only think, it's only an African disease. As I've said, the world didn't really took notice of this, except now that the first world all of a sudden wants to sit up straight. Because it might affect their people, but when it affected Africa for the last 30 years, no one really cared about that. And then how do we control your rodents, other animals, so that we lessen the rodents to human transmission? But also remember, we have now said it mutated, so human to human transmission now is one of the main things that we are seeing. And then sometimes these atypical presentation that they can have. As I've said, not all people have those typical blisters that you see in most of the television, being shown on television, or being, you know, pictures that you see in the media. And again, we need to understand the viral evolution. There's a changing epidemiology. There's other modes of transmission, the adaptation that we now see in humans. Again, clade 1b, that is a problem. It's a fast-spreading viral infection, and with a much higher mortality rate. Don't need sex to sex, close contact droplets transmission, which you don't really see with the clade 2b. And then we need to control and need to have better control in endemic areas. Vaccination might be a problem. Access to healthcare to some of these, for some of the people, especially in Africa, might be delaying the diagnosis and treatment. And then I believe that there are much more cases than what is reported because of this difficulty in making a lab diagnosis, or people who have mild symptoms and do not even bother to go to a clinic or a healthcare worker. I hope this is just a brief background, and I hope it makes sense.
Yeah, so ma'am, as we look to the future, what steps could global health organizations, governments, and communities take to better prepare for and prevent similar outbreaks? And what message would you like to share with policymakers and public in general regarding this?
I think if I can, for policymakers and other countries, if something develop in Africa, if you know there are viral infections in Africa, and if you see that when it started originally as a zoonotic disease, but then start to change, there's the virus then changed to from direct human to human transmissions, then we should take much better notice of that. Then try already to get a vaccine on the market, and then try to educate those countries and the people living in those infected areas, and to try to contain the spread of the infection. So we need control, much better control of these type of viruses in our endemic regions. We need to make sure that the clade 1b, I don't know how we're going to do that, but we need to make sure that clade 1b, the outbreak that we have now seen since 2023, 2024 in Congo, should be contained there, because that is the dangerous one. Again, the need for vaccines, please, we need vaccines, and again, education. Improved surveillance from all the countries and countries with close borders to these countries in Africa where it's endemic. And do not, again, do what we have done during COVID. Do not unnecessarily create fear among people. Make sure that people understand the clinical symptoms. Make sure that people don't go and discriminate against other countries where there is currently, or the endemic countries that we are now seeing. And again, first world countries, please do not hoard all the vaccines for your own people. They actually started in Africa, and no one can be safe until Africa is safe.
Yeah. Thank you so much, Dr. Coetzee, for sharing your valuable insights and expertise with us today. The M-Pox crisis is a critical issue, and your guidance is essential as we navigate these challenging times. We greatly appreciate your time and dedication to global health. Thank you once again for joining.
Thank you so much, and have a great day or night wherever you are, and please take care of yourself.
Thank you very much, ma'am.